No. Effects are significant, but they're not universally durable. The question is, this emergent evidence, is it really going to reshape how we conceptualize dual diagnosis treatment? And if so, how? What does it mean to say that someone has treatment-resistant depression? That means they have had adequate trial, at least 2 depression treatments, and failed it. And now, psilocybin has entered that conversation. 25 milligrams dose demonstrated a statistically significant and clinical meaningful reduction compared to the 1 milligram. This is not cure, it's an intervention with temporal limitations. Addiction and depression share reduced cognitive flexibility. If my mood is good, why would I self-medicate? Without training pipelines, psychedelic integration really remains limited to specialized centers. And most of the time, the people that have access to these specialized centers are going to be people from high-income populations and certain ethnic backgrounds. If you're going to say someone has depression, you have to be able to say why they don't have bipolar. It's possible that psilocybin may improve and decrease addiction rates, but it's not proven. Scientific caution is not skepticism, it's protection. Hello, and welcome to the Transformed Minds. This is the podcast where we explore the real-world intersection of mental health, addiction, and transformative care. I'm your host, Dr. Owusu. Most people call me Dr. O. And with each episode, we take a very thoughtful, practical, and evidence-informed look at how we can improve psychiatric and addiction care, from the clinical settings to the community spaces we work in. If you're new here, here's the vibe. We have our Expert RX, where we bring in brilliant minds from the field, clinicians, researchers, change makers, advocates, and they share their expertise with us. We also have our Lift RX. That's where the real-life stories come in. Guests who have lived it, they have survived it, and they're experts in reshaping the systems because of it. And we have our host, RX, where it's just me and you. We break down the literature and what matters for us. Today is the host, RX, and I'm so glad you're here. This would be a continuation of us breaking down psilocybin and what that really means for us. In the last episode, we talked about psilocybin in the context of alcohol use disorder. Today, we will look at psilocybin in the context of major depressive disorder and substance use because they are deeply intertwined. Let's turn to one of the most visible and rigorously conducted psychedelic trials to date, which is a phase 2 randomized controlled trial of psilocybin for treatment-resistant depression that was published in the New England Journal of Medicine in 2022. So at first glance, this is a depression study. But if you practice addiction psychiatry, you know this is also an addiction study. Major depressive disorder and substance use, like I mentioned before, they're deeply intertwined, whether it's biologically, behaviorally, structurally. Treatment-resistant depression often coexists with alcohol use, opioid use, stimulant, cannabis use disorder, and mostly it's because people are trying to either self-medicate or make themselves feel better. That becomes their coping mechanism. The architecture of rigidity, cognitive and emotional, neurobiologicalness of it is shared. So the question for today, it's not really whether psilocybin reduces depression symptoms in a trial population. The question is this emergent evidence. Is it really going to reshape how we conceptualize dual diagnosis treatment? And if so, how? So let's take a look at this Godwin and colleagues study. So it was a multi-centered study. As I mentioned, it was randomized. It was double-blinded, which means the rigorousness of it is higher. And it was in patients who have treatment-resistant depression. And what does it mean to say that someone has treatment-resistant depression? That means they have had adequate trial, at least 2 depression treatments, and failed it. So they've tried medications with therapy, didn't work, because as we all know, currently what the evidence shows is medication and therapy together gives you better outcomes and is more effective compared to therapy by itself or medication by itself for depression. But studies also show that the most effective treatment for depression is actually electroconvulsive therapy. There's a subset of people who have tried all these different modalities that are there, multiple ones, and still have not gotten any effect. They may have tried it and have not gotten any effects of it. So if people are then have this treatment resistance depression, that now psilocybin has entered that conversation of, is it possible that we can use this to help? So that's what Goodwin and his colleagues looked at in this multi-centered, randomized, double-blinded trial. So what they did was the participant in this study received a single psilocybin dose, so either 1 milligram, 10 milligram, or 25 milligram, but they also received psychological support. So if you look at the structure of this study, it's a little bit similar to the one that we looked at in the last episode for alcohol use, where they had psilocybin with psychotherapy. It wasn't just psilocybin by itself. It was in a structured setting as well. So when we look at this study, it's kind of like the same thing, a little bit similar. The participants are receiving the psilocybin, but they also are receiving it with psychological support. The primary outcome was a change in the MADRS score at 3 weeks. And what the MADRS is a Montgomery-Asperger's Depression Rating Scale. So this is basically a tool that we use as clinicians. It's a 10-question administered tool that is used to assess the severity of depression in adults. So that automatically tells us that the participant in this study were adults. They were not children. And the score ranges from 0 to 60, which is the total score. The higher the score, the greater the severity. And this is widely used in clinical trials to monitor treatment response. It focuses on symptoms like sadness, sleep, appetite, suicidal ideation. So on the scale, 0 to 6 is normal. So 0 to 6 means no depression. 7 to 19 is mild depression. When you're in the 20 to 34 range, that's showing that you have moderate depression. And then 35 to 60, those are the higher ranges where we're seeing severe or extreme depression. The items rated includes apparent or reported sadness. So the person can verbalize that they feel sad, or you could see it from their affect, which is what we see as clinicians when we're looking at patients or individuals. Inattention, reduced sleep or appetite. So basically all those symptoms of depression that we often may see or people will endorse. So when you think about SIGI caps, which is like an acronym that most of us use when you're going through your medical school training and you're trying to remember some of these symptoms and differentiate them from other ones, right? The clinical utility of the scale, it's really a reduction of at least 6 points is considered clinically meaningful change, whilst 12-point reduction indicates a clinically substantial change when you look at how to utilize this scale clinically. It is completed by a clinician on a patient interview, so it's not one of those self-reported like the PHQ-9, all of those things. But this one is actually clinician-based, so meaning clinician-administered. It's completed by the clinician based on whatever interview they had with the patient. The reliability of the scale generally ranges from 0.89 to 0.97. So it's really useful clinically. It helps really when you're trying to track how someone is doing based off of the treatment that you may be offering them. So they're looking at a change in score at 3 weeks from day 1 of taking the medication to 3 weeks. And then the results show that 25 milligrams dose demonstrated a statistically significant and clinical meaningful reduction compared to the 1 milligram, right? Remember I said people got 1 milligram, 10 milligram, and 25 milligram. So at the end of the study, they're seeing that the people that receive the 25 milligram dose are showing not just a statistical significant, but also clinical meaningful reduction. I remember what I said, when we see a 6-point reduction in that Montgomery Asperger's depression rate and scale, that shows that there is a clinical meaningful reduction. And adverse events that came up from the psilocybin doses that were given included headaches, nausea, dizziness. Suicidal ideation occurred in some participants during follow-up, underscoring the need for monitoring. We already know suicidality is a symptom of depression, but what this is also showing that it was an adverse effect of given psilocybin. So some of the limitations of this study is short-term follow-up. It's at 3 weeks, so we don't have that long-term follow-up there. Limited ethnic diversity. This is a huge thing. I stress the importance of access, of diversity, of inclusion, because how can you say a study is generalizable when it was only focused on a specific group of people? That means I can't take this study and expect it to give me the same results that you got, because the study was not tested in those individuals. I can't say this outcome applies to that ethnic group based on this. So we need more research that includes a lot of other ethnic minorities. And mostly these gaps are focused on ethnic minorities. And it's a lot of different factors that goes into that. When you think about Tuskegee is one big one that comes into mind when I think about the relationship between medicine, research, and minorities, especially people of color, Black Americans, African Americans. Henrietta Lacks, it's another big one that comes up. And if you see or think of how this group of people have been treated historically, you then come to understand the relationship they currently have, that lack of trust they currently have for the medical system. And that then can influence if they're going to sign up for a study or not, if they're going to participate in a randomized controlled trial testing for things. So it's a lot of these historical events that also play a role in recruiting people. On top of that, their policies. A few weeks ago, a lot of research, funds, grants that went towards work that focuses on minority groups and marginalized populations like addiction, homelessness, all of that got pulled, got scratched off, right? So you think about it's a lot of different factors that can go into why there is limited ethnic diversity in a study. When I talk about all these things, it's not that I'm pointing fingers, but one is to bring awareness to the people that are listening that may not be aware. But two, it's also a call to action to you that's listening, because you may think, what has this got to do with me? I have no role in making these. Yes, you do. You have a role in making changes. You are voting for the people in power, making those population-based decisions that affect us from top down. So the funding that goes towards the research, which populations get certain programs, which population has certain access. Like you, the person that you put in the White House decides who's in charge of health and human services. The Health and Human Services Department of the country, right? Whoever is in charge of HHS, the person you put in that White House is the person that picks that person. And that person can decide to say, let's not vaccinate our kids. And then all of a sudden we see measles rising again. So we all play a role, from the doctor to the individual that's receiving the treatment. We all play a role, because a lot of what we do are regulated. There are policies that comes with it. And your voice makes a difference. And this can be your voice. Calling that representative, sending a letter to your representative. That can be your voice. Your voice is needed. Making a post on social media to create awareness, right? Because a lot of us are on social media now. You make a difference. Your voice makes a difference. So let's just get back to some of these limitations. Psychological support was structured, but it wasn't full psychotherapy. So like the last episode that was focused on psilocybin alcohol use, we saw that trial. Actually, that trial was published in JAMA. We saw that they had a full-on psychotherapy. embedded into that trial. This one just is given psychological support and not a fully structured psychotherapy. Within broader literature, the early work by Carhart Harris and his colleagues have suggested that psilocybin can alter and will alter default mode network connectivity and increases neural entropy. Addiction neuroscience similarly sort of implicates this rigid network and connectivity, maladaptive salience attribution. So all of that is the same, whether it's alcohol use disorder that we're looking at or we're looking at depression. So translational hypotheses shows that psychedelic-induced flexibility may disrupt that entrenched depressive cognitive and addictive compulsivity. But this, again, it's all theory without direct dual diagnosis, randomized controlled trials. So in this phase 2 double-blinded trial, a single 25 milligram dose of psilocybin produced significantly greater reductions in depression at 3 weeks compared to 1 milligram control. The primary endpoint was a change in Montgomery-Åsberg depression rating scale. The 25 milligram group showed a clinically meaningful reduction, and we said this is a 6-point reduction in the MADRS scale. However, response durability diminished after 12 weeks for many participants, right? So this is not cure, it's an intervention with temporal limitations. At week 3, we see change. At week 12, that change dissipates. And we're seeing this from this study. So if psilocybin transiently enhances neuroplasticity and emotional processing, can that window be leveraged in addiction populations with comorbid depression? The 25 milligram dose shows significant reduction at 3 weeks. Effect size is meaningful. Though the effect we're seeing is not universally sustained, it's still meaningful. Clinically, this resembles other rapid-acting antidepressant paradigms such as ketamine, though the mechanism between ketamine and psilocybin differs. For addiction psychiatry, rapid mood improvement could really reduce relapse risk in comorbid patients, but only if we're integrating that into a longitudinal care. And I can see how this can really play into what we're doing, because I can think of a patient that I have right now who is going through these cycles of recurrence of alcohol misuse. And it's mostly because they're like, I feel bored and I feel sad. So they go back to use. And we've tried so many different medications, and this is where the complexity come in. We've tried multiple medications, we've tried different modes of therapy. The individual is unable to fully participate in that modality of care due to social determinants of health. There is this limitation of inability to read that they're not able to participate in DBT, which can possibly be very helpful for this person. So we're looking for different ways where we can fully engage this person in dialectical behavior theory to help them, because there's also a personality component in this complexity and comorbidity. So we need different modalities of care to help, but we have limitations. And I say social determinants of health because education is a huge social determinant, and we see how that's affecting someone actually participating in treatment. And it's sad. It's sad. And I would hope that will not be the case for people, but unfortunately it is. So treatment like psilocybin and it being clinically meaningful to use for people that may be going through those rapid mood improvement to reduce their relapse risk, it can be very meaningful in what we're doing. But we have to be able to integrate it into longitudinal care, because what the study is showing that is not a sustained effect, is not a sustained improvement. The outcome is not sustained past 12 weeks. So we have to find how we can use what we're seeing and the effect that we have clinically to improve care. how can we integrate it into the care that we're given to addiction populations. So in the last study, we talked about how certain populations were excluded. In this study, it's very similar as well. People with psychotic disorders and mania still remain a risk. If they're excluded from the study, then we don't really know how psilocybin in this population is going to play out. So we need more studies, but we also have to be careful as to how we're implementing the studies. And those study protocols, when built, should take into account what are the risks, what are exceeding the risk, and the safety of implementing these trials without causing more harm to people. So if certain populations need to be excluded for their safety, then let's do that. Addiction populations have higher rates of bipolar spectrum disorders, so careful screening is very essential. We see that societal ideation was one of the adverse effects of this trial, so follow-up should emphasize structured monitoring and very robust risk assessment. If we know that there's a possibility that someone taking this is likely going to have some suicidality, then why not build a structured follow-up, close monitoring, risk stratification, all of that into the study, the trial, to prevent these things, to mitigate that adverse event? Is antidepressant mechanism relevant to addiction? Of course. Addiction and depression share reduced cognitive flexibility. That maladaptive rumination, when there's that impairment in your cognition of these recurrent thoughts, you can ruminate over the most irrelevant things, but they take so much time, so much headspace, and you're like, what is going on? And then imagine on top of that reward circuitry dysregulation that may also happen. So depression and addiction share all of these things, right? It's common to see it in both. So when you have depression and comorbid substance use, that it puts us in a synergistic effect. So is the rumination more? Is that impaired cognitive more than if I had just one? Yeah. Psilocybin's serotonin agonism may actually increase synaptic plasticity and disrupt that rigid network dominance. However, addiction also involves the dopaminergic reinforcement loops, that reward circuitry, and it's not fully addressed in the study that we're looking at. So we need more studies that address all of these things and the limitations that we talked about earlier. Mechanistic overlap is promising, but incomplete. Could this reduce substance use indirectly? I think improved mood reduces self-medication behaviors. So if my mood is good, why would I self-medicate? Yet we lack randomized controlled trials directly examining dual diagnosis populations using psilocybin for depression with substance use endpoints. Clinicians must resist this extrapolation beyond data. The workforce implications really includes, again, if we're going to be doing this, we need well-trained facilitators. It needs to be in a structured, controlled settings because it comes with adverse effects. We need to monitor. Monitoring protocols are going to be very important to save lives, to reduce risk. Addiction systems already face a workforce shortage, so integration of this without infrastructure really risks inequality and inequity. And we don't want to do anything that increase the burden we already have and the barriers we already have. The American Medical Association has emphasized the need for evidence-based workforce expansion in behavioral health. And we all keep asking for that. Without training pipelines, psychedelic integration really remains limited to specialized centers. And most of the time, the people that have access to these specialized centers are going to be people from high-income populations and certain ethnic backgrounds. And we don't want to do anything, again, that plays into that. Regulatory considerations, we already know currently is Scheduled 1. If FDA breakthrough therapy happens, then designation for some psychedelic compounds will signal a regulatory change. Because Schedule 1 is saying there's no medical use for this. So if we have some breakthrough and we have some medical use and it's going to help for depression, it's going to help for alcohol use disorder, all of these things, then we're going to have to revisit the regulatory policies that are currently in place. And I think one of that would probably be REMS, right? We see like REMS-like programs that are already in place for similar scheduled drugs, and maybe this can be one of those things. Again, credentialing standards, outcome monitoring, all of these things. So let's implement this in the case. We have a 38-year-old woman with recurrent major depressive disorder, multiple failed therapy, SNRIs, co-occurrent alcohol use disorder, which is in early remission. So clinically, she meets criteria for treatment-resistant depression. Current options, either we optimizes her current medication, augment strategy, like I said, ECT, TMS, ketamine. Right now, it's not. But risk assessment must include bipolar screening, psychosis, active substance use, stability. Just like when you see any other patient that you see for the first time and you're doing your initial assessment, like your diagnostic assessment, you have to assess for all other major psychiatric disorders and rule them out. If you're going to say someone has depression, you have to be able to say why they don't have bipolar, because we know bipolar 1, mania. Bipolar 2, you have mania, hypomania, or the depressive. Bipolar has depression. Major depressive episode, manic episode, they come together and make bipolar. So if someone has bipolar, you have to be able to have already ruled out bipolar. And if you're not able to say that in the moment, you have to be able to formulate why and what your thought process is. Systematically, insurance coverage is it's uncertain. Even the medications that are already approved, we have trouble getting insurance to pay for some of them. So you can only imagine. Access, again, limited to research settings. And we're going to need structured monitoring. Without careful implementation, dual diagnosis patients may be excluded from emergent therapies due to risk aversion. So we need more studies to figure out the people that have these dual diagnoses. Is there a possibility to include them in the studies? So what distinguishes a phase 2 trial from a phase 3 trial? If you're a trainee or allied professional clinician listening and you're not well versed in research, phase 2 assesses dose ranging and preliminary efficacy, not definitive. What monitoring protocols really require post-psychedelic administration should be acute supervision, suicide risk assessment, follow-up visits, and right now, there's no evidence for psilocybin to replace our standard antidepressants and treatments that we currently have. Evidence is supporting an investigational, adjunctive role, whilst these research and trials are still ongoing. If you're a policymaker, no. Effects are significant, but they're not universally durable. We still need regulations for safety, abuse potential, the need for controlled administration. Indirectly, it's possible that psilocybin may improve and decrease addiction rates, but it's not proven. There's some study there. There's something there. I'm trying to classify the something, right? We have something, but it's not substantial and it's not really proven. It's like indirect. So we need to do more studies to figure out what's going on. So here is a summary framework from what we've discussed so far. Depression and addiction is not simply sadness. It's cognitive rigidity plus reward dysfunction, which makes it complex. Psilocybin may create a temporary state of increased psychological flexibility from what we're seeing, but 3 clinical questions can determine appropriateness. Is this patient or is this treatment-resistant depression? Does the person have psychosis or bipolar disorder? Have you ruled those out? Is structured support available? If you don't have these things, according to the study that we're looking at right now, then your risk outweighs the benefit. You have to be able to answer these questions, and the case be treatment resistant, psychosis and bipolar disorder excluded, and have structured support for you to say, okay, this is in line with what the current evidence is alluding to. So In closing, clinicians, evidence is promising, but it's only preliminary. We need more information. We need more data. We need more work to figure out where we're heading to, and is this conclusive? If you're a trainee, understand the mechanisms before policy enthusiasm. If you don't understand how it's working and how it's helping, don't be jumping ahead of yourself. For policymakers, regulation must protect without obstructing research. Yes, we want regulation. We want things to be monitored, but don't obstruct the research, because we need the research to figure out how we're going to appropriately and safely do this. For the general public, our listeners, scientific caution is not skepticism, it's protection. There's so many newer things that are coming out, newer treatments, but we still have to investigate a lot of them. And I'm learning alongside of you. We are learning together. So thank you for listening. Thank you for learning with me. And as always, stay ready, stay aware, and stay grounded.